If you were a general hospital, it was probably closer to approximately 40 or 50%. Because cancer is such a horrible disease, because it's such a deadly disease, the average oncology sort of practice in the United States dropped closer to about 40%, where if you think about that for a moment is a massively alarming number. If you think about 10 million deaths around the world, if you think about 1.8 million new diagnoses of cancer, and all of a sudden you say, well, 40% of those patients are not going to get care, it absolutely is frightening. For Cancer Treatment Centers of America, because we're national, because we have a very reputable brand, we were down kind of in the initial phases, sort of in the 18 or so percent as an organization. But as a human element, it was really challenging to see cancer patients who already are some of the most wonderful, loving, and resilient people, now having this new unknown out there. They are struggling with this disease, which sadly, if not treated, will kill them. And now they are hearing about this kind of unknown virus and a wide range of data on what might affect them or not. So I had dozens of conversations with patients, and it was heartbreaking to really think that those patients were having to think about deferring their treatment or having a provider delay their treatment. But in summary, Michael, and I'm happy to talk in much more detail about any of these topics or if people have questions, we have, I think, responded very well. We really have told we've looked at every patient individually, found a safe way to get them treated. The bedrock of cancer therapy for 20 years has been catch it early, treat it consistently, finish the treatment. So we have really kind of abided by that mantra to really stay on top of the disease and create as safe an environment as humanly possible to treat our patients. So we've really had to sadly reduce the amount of visitors. We've created a single entrance with screening of history, screening of temperature, screening of rapid testing for COVID-19. And if they pass those, the patients can come in. So I feel good about the fact that we're still treating, thousands of patients and hopefully saving their lives. But I can tell you it's been a real challenge from the patient aspect to getting protective equipment to just navigating the unknowns of COVID. So maybe I'll just pause there as an intro, but happy to go in any other direction that you'd like.
No, Pat, that's an awesome introduction, and I really appreciate it. And what comes to mind is how patients are being affected through this and having to make some of those decisions. And you're taking all these preventative steps and helpful steps. But do you see patients being affected because of maybe an adjustment to a treatment pattern or a pause that they're placing on their treatment as a result?
I do, Michael. I would frame the following in kind of these buckets. By and large, as I said before, we have been able to resume a fair amount of our treatments for our patients, but there's kind of two phases maybe that I should talk about. In the first phase, we had a lot of patients who called us that had disruption in their treatment due to one of a few factors. Number one, let me actually just say this first. COVID-19 is a serious viral illness and a serious pandemic, full stop. Anybody who tells you otherwise, I'm sorry, they're just wrong. It is a real infectious disease. Now, on the flip side, cancer is a horrible disease. What we as a nation, as a society, have dealt with too much during this pandemic is too many choices between false choices. You either treat COVID or you treat cancer. Absolutely incorrect. There's other examples of that. For anybody who's a servant of the military or a fan of military history, a lot of analogies have been made to war, certainly the war on cancer and the war on COVID. You would never have said in World War II, we either have the war in Europe or the war in the Pacific. No, you have to win both, right? And so I just want to be clear about that. Now, number one, in the initial phases, patients heard something from a governor or a mayor or a president, and it was, for lack of a better word, confusing. Okay, well, surgeries are canceled or medical things are canceled, so they didn't know what to do, number one. Number two, they called the hospital, and the hospital had a temporary shutdown, so they couldn't get their surgery, they couldn't get their chemotherapy, they couldn't get their radiation. Or number three, they called their doctor, and the doctor said, well, we're getting these mixed messages, we don't know what to do. That to me was sad to see. We owe our patients an environment where we allow them to make the decisions, but we should inform them with clear decisions as members of the healthcare community. And around the country, that was broken. I'd like to think that we did a pretty good job of it. So we ended up getting patients transferred to us from about 100 different hospitals around the country that were either overrun with COVID or dealing with COVID or those types of things. So that was the initial phase. In the second phase, what's happened, and this is sad to see, is cancer gets diagnosed in one of two primary ways. You go in for a screening. A woman goes in for a mammogram. A man goes in for a prostate check. Somebody goes in for colonoscopy. You go in for labs. That's kind of category one. Category two is you go in for something else, or you go in for a symptom, and sadly, it turns out to be cancer. You go in for weight loss, you go in for trouble swallowing, you go in for just something. Because healthcare visits in general are down, and because screening is down, there's been a massive reduction in cancers diagnosed in the past 90 days. I've spoken in the media about something I call the shadow curve, and it has to do with the fact that as we flatten the curve of COVID, so to speak, there is a shadow curve that is rising in American healthcare. Cancer, heart disease, neurologic disease, that shadow is rising. And one of my missions is to prevent a study in the year 2023 that says we had 300,000 more people die of cancer in 2020 because of disruption, right? Or we had 1 million cases that would have been stage 1 go to stage 3 because those patients didn't get caught until later. And instead of a lumpectomy for a breast surgery where they just take out the mass, that patient had to have a bilateral mastectomy, meaning both breasts surgically removed, or they had to be on, some sort of, more intensive treatment. So to give you some statistics, mammograms are down 90%, colonoscopies are down roughly 70%, other screening measures are down 70 to 80%. Studies show that we as a society have probably missed diagnosing approximately 100,000 cancers, maybe as high as 300,000 cancers during COVID. And if you look at the math, 1.8 million cancers every year in the United States diagnosed newly. If you took a quarter of that, that would roughly be 450,000. And if you think about 90 days of disruption, not to mention where we are now, those numbers, as big as they are, they start to make sense. So Michael, we're kind of really dealing with getting patients treated, but also trying to make sure that patients are not getting diagnosed later or missing their diagnosis.
So when you think about the future as opposed to our current state, and how I think people in general, when it comes to healthcare, might be a little bit more hesitant to going into a physical hospital or office setting. Is there a preparation being done? It's like, what do you see in the future in terms of different ways of diagnosing cancer, just in light of a more virtual environment?
Yeah. So let me answer that question directly first, and then I'll I'll take some liberty and answer a question that I thought you would ask around sort of safety and preparedness in general. So to your direct question on kind of modern techniques to use and the like, As I mentioned before, in 2013, I helped found a company called Doctor on Demand. It's one of the largest telehealth providers in the country. I'm a big fan of telemedicine in general. It sounds, to the average patient, initially it sounds a little weird, but imagine the first time you used an ATM. It was, crazy to think that, whoa, you're going to pull cash out of this machine, or you're going to deposit cash into this machine. There's a lot of things that just hit our neurons or hit our behavioral kind of mind, and it's hard to adjust. But telehealth in general, I can tell you, for a variety of things that you go into the doctor for, from rashes to certain traditional urgent care issues, telehealth is a great solution for those, by and large. In cancer, it can help, but right now, until the iPhone can do surgery or do chemotherapy or do radiation, which hopefully 10, 15 years from now, some Illinois engineers or those of us on the phone can help push that down the road. It cannot. So telehealth has a role in cancer therapy. It can get you connected very quickly to our oncologist to ask a question. It can help arrange a second opinion. It can buy you a little bit of time, a week or two, to sort of pause as you're wondering about things. But if we are trying to eradicate a cell that is growing malignantly in your body by cutting it out with surgery, by killing it with chemotherapy or killing it with radiation, in the treatment phase of cancer, 99% of things are still going to need to be done in the foreseeable future, kind of in person. And so in the same way that an orthopedic surgeon can consult with me on my torn tendon, can tell me about range of motion and prognosis, and even check on me after the fact, I still need to go in to actually get that tendon operated on. It's kind of the same there in cancer. So Michael, hopefully that is helpful there. In terms of the question, maybe I thought you were also going to ask, is preparedness and safety. In my time at the White House, in my role as essentially roughly a Fortune 500 size organization CEO, I would say this: the next time a pandemic comes around, the United States will be much better prepared. End of sentence. It is a must. If you look back over the last 10 to 15 years, we've seen new viruses emerge, from SARS, MERS, H1N1, Ebola, Zika. We need to assume that new viruses are going to emerge. That's not meant to be fearful. Quite the contrary. We should expect it, but we should be prepared for it. We had a disaster of a time, an absolute disaster of a time, trying to figure out. I mean, there was just very little coordination. We were paying, we literally were having to pay an 800% markup to buy masks and gloves for our doctors and our nurses. We were getting mixed messages from the government in terms of whether this mask would qualify or not. I was reaching out to other CEOs to coordinate care, but there was very little sort of coordination that said, oh, well, Pat, you have beds that you can take cancer patients from, for example, the University of Chicago, and that will open up more beds where they can treat COVID patients. We had to do those things individually instead of a coordinated plan. So number one, the country will be better prepared to respond in the future because we need to be. Secondarily, in terms of creating a safe environment for patients to come in, we can, and never again should we tell patients, don't get medical care. That was irresponsible. I think 99.9% of people would probably go back and say that was a mistake. But what we should tell people is, call your doctor, call your hospital, only go there if the following protocol exists. Are they screening you for your risk based on your age and your disease? Are they screening you based on your history and your temperature? Are they checking your temperature when you arrive at a distant location? Are they testing you with rapid testing? So that's what we do right now. We feel that, we can deliver a safe environment, and we have to be prepared for that because, come December and January, what is likely going to be the case is that COVID will be here in some fashion, but then we'll have the new flu season and things on that. And again, we can't tell patients with cancer or stroke or heart disease, don't get treated. We have to find a way to treat them. And I feel confident that when done the right way, without politicizing things, we can acknowledge that this is a serious illness, but one that we can work our way through safely to make sure that people get the care that they need.
So one question off of one of your comments in regards to, call it the lack of our, like a communication trail or understanding where our resources were when and how to access them. Was that something as in your role as a CEO of a Fortune 500 company? I mean, is it something that as a country we just did not have in place? It was a structure that was not there that we've had to create on the fly?
Yes and no. So if you look at some of the things that the government has, it's dangerous in these political times, but from a natural disaster perspective, there are national, state, and local preparedness plans. From a, God forbid, a national security perspective, meaning defense, there are plans. Healthcare did not have as many of those, but they did exist. But where they existed, we, how should I sort of phrase this? We had those plans way on the back burner, or nobody had dusted them off, or they had been kind of thrown out for some time. So let me give you some very concrete examples. Production. The United States of America spends $3.5 trillion, roughly 19% of GDP, on healthcare alone. It's more than $10,000 for every man, woman, and child in America. It's massive. It's 60% high, 50% higher than what would be predicted by most models. And yet we couldn't glove and mask. I see a question on the screen from Dr. Sheila Kanda, a breast radiologist. We couldn't glove and mask our doctors and nurses, right? We couldn't even do so, 2 months into it. One, the stockpiles were not well tended to. Two, our ability to ramp up production was not there. And three, there was a lack of coordination. In a natural disaster or national defense structure, I'm not going to pretend that any crisis gets handled perfectly. And in fact, you can look at prior examples. There's a lot of chaos there. But at least the FBI is working with local law enforcement, or in the natural disaster scenario, FEMA is working with local, programs. There was very little of that really tried to coordinate resources in the Chicago area, in the Los Angeles area, in the Phoenix area. People did rise to the occasion to do that. So Michael, what you'll see going forward, I think, is much better planning. Number one. Number two, much better infrastructure to prepare to ramp up. Better regulations to allow for telehealth to quickly ramp up when need be, and just better technology. It shouldn't take months to develop a cheaper, faster, ventilator. It should be, every other sector of the American economy would produce those things quicker. So yes, I think you will see a better response, hopefully in the months ahead, but definitely in the years ahead.
Thank you, Pat. I appreciate all the explanation. Can you comment on, and this is from Dr. Cheryl Lentz, can you comment on treatment breakthroughs that are often accelerated as a result of force changes, things that might not happen at normal speed?
Absolutely. I think what that question, I believe, is sort of referring to is innovation, is often accelerated during times of crisis or breakthroughs, or sort of when you have to. I'll give you one example that I'm optimistic about is the production of a vaccine. Is normally a slow, drawn-out process that is not even measured in months or years, but sometimes in decades. I am hoping that on the healthcare side, we will collaborate and coordinate to develop a vaccine much quicker. Cancer, certainly there are examples of that. The progress that we've made in immunotherapy in the recent years is nothing short of amazing. Some of the cutting edge treatments that we can have now are absolutely, they should give people a great deal of optimism and hope. As far as this goes, in terms of, I think what the nature of the question is what will this crisis do to accelerate certain changes? A few. Across healthcare, to a certain extent in cancer, but unfortunately not as much because of what we have to do. Telehealth, I think you'll see a lot more innovation in telehealth and what I would call its sister therapy, which is remote monitoring or at-home monitoring. Using video technology, using wearable devices or implantable devices, we can treat a lot more conditions, not just the acute urgent care stuff like a doctor on demand, but chronic care things. Diabetes, if we could get ways to have in-home monitoring of blood sugar, and an implantable that's giving you a hemoglobin A1C reading and things like that. So I think you'll see an acceleration in those types of technologies. I think you'll see an acceleration in the policy procedures of how the United States and the states kind of respond to pandemics in the future. I think we'll be much more prepared going forward. And then other things, the tech-enabled arena of healthcare in general, you're going to see a massive acceleration in. I've been a part of that world in the past. We do some things with it at CTCA. Everything has pointed us in the direction of do more of that. We have a business that helps coordinate local cancer providers to care for patients in their neighborhood with our level of expertise and protocols. That has massively, accelerated. We have a program that, again, on we call it the virtual cancer clinic, which allows patients to sort of connect with us remotely. That is accelerated. So I think you'll see a lot of those things in addition to some of the things that I mentioned before.
Thank you, Pat. I really appreciate it. And the thoughtful response makes me think about other things. It makes me think of a previous response that you had in regards to that study that you were talking about. I think you had said you did not want it to come out, but just talking about the shadow curve.
Yeah.
And with the incidence or the higher incidence of cancer diagnoses, or at a higher degree or a later degree, do you see other innovations that are being worked on within the cancer treatment world that are being worked on in order to address that particular issue in and of itself?
Yeah. So again, just to kind of rephrase that point, this idea is like other aspects of human life. Healthcare is notorious, and I shouldn't be so hard on it because it's a part of civilization, right? You advance by learning from the past. But healthcare, I'll give you the funny example, right? How many times have you guys seen an article that says, eat more carrots? Oh wait, eat less carrots. Eat more red meat. It's good for eat less red meat, right? There's constantly this, were we wrong or were we right? But there's another set of studies which is sort of, geez, we should have predicted that going forward. That's the study I'm trying to prevent. I am very fearful that we will look back in 2023 because of the shadow curve and say, we had 1 million more deaths that could have been prevented because of cancer and heart disease and other things that should have been prevented, but we didn't. Now, what's going on to prevent those things? I'm an optimistic guy who generally is kind of always looking for solutions and the positive. Right now, Michael, the short answer is there's not a lot going on. What we are trying to do with the American Cancer Society and other large cancer providers, us and Memorial Sloan Kettering, MD Anderson, is we're trying to just get some public service messages out, which basically just say, don't miss your screening, don't miss your appointment. Again, going back to this world we're living in, where it's like you have to choose between the extreme on one hand and the extreme on the other. It need not be that way. We should be able to tell people, call us or call your doctor, make sure there's a safe time and way to get in with masks and gloves and temperature screening, and let's get you taken care of. And so right now, to prevent that, Michael, the sad news is, until we start acting like a society again and a coordinated country again with the communication, we're not doing a good job of preventing that, because there's just so much useless kind of noise and argument about basic facts that people are not focusing on the right solutions. I see a question later down here from Mark James about, what should be the right solution. The right discussion will be, how do we get the right patients the care that they need at the right time? But sadly, Michael, other than the sort of public service messaging that we're doing, if things were to continue this way, we are heading for that 2023 study that shows that people are going to die of more heart attacks and more stroke and more heart disease. Look, in healthcare, there are three things that we sometimes talk about: medical determinants of disease, meaning the cancer therapy that you get; behavioral determinants of disease, which is your emotional well-being; and then social determinants of disease, which is your access to healthcare, your access to means that can provide nutrition and the like. What's happening is the debate, sadly and erroneously and unfortunately, has been turned into healthcare versus the economy, or lives versus the economy. It should be healthcare versus healthcare, or lives versus lives, because eventually, if you stop the medical determinants of disease and patients going to get treated for cancer, obviously there's going to be a lot more deaths over there. If you do enough things that cause behavioral determinants of disease to rise, anxiety, depression, abuse, homicide, those rise. And then the social determinants of healthcare, obviously recessionary things and other things that can also, cause some healthcare damage there. But that's not the debate that's being had. The debate that's being had is this artificial one between kind of health and the economy. So anyways, Michael, I'll pause there.
No, thank you, Pat. To get to Mark's question, specifically to your point about the shadow curve, was it necessary to abandon the centuries-old practice of isolating the sick and most vulnerable versus the massive lockdown of everyone as it pertains to our approach with quarantine and healthcare?
Yeah, very, very, very good question. So a few thoughts on it. Let me kind of lay the foundation again by just so that there's no mistake in my words or my comments. COVID-19 caused by the coronavirus, which, by the way, coronavirus is an existing family of viruses that have existed for a long time. Frankly, many of us have probably had them in the past. It's just a new strain of this particular kind of COVID-19 disease. It's remarkably serious. Anybody who said don't take it seriously or ignore it, foolish, non-scientific, non-clinical, non-believers in data and facts. That being said, how do you respond to it? Mark, to your question, a couple of things. In times of crisis and decision-making, you have to act with kind of clear confidence, clear communication. You have to sort of know which way you're going, or at least pick one side. If you look at the United States response compared to other countries around the world, you can't be in the middle of the road. So you can't say we're going to have a massive lockdown. If that's the choice that you're going to go down, and I'm going to comment on my personal beliefs in a moment, but if you're going to go down that path, you can't say it's kind of a massive lockdown. right? You can't say it's a lockdown in Illinois, but not in Indiana. You can't say it's a lockdown in California, but not in Arizona, right? You can say it's a lockdown, but kind of, right? You have to take it seriously. Otherwise, what you were trying to accomplish with that fails. And what you're trying to accomplish with that is the following. A virus has two very important factors to it: how deadly it is and how contagious it is. How contagious it is measured by something we call an R0 factor. It's basically a geometric measure of, if one person has it, how many other people will they affect? You can bring that number dramatically down through social distancing and by essentially quashing the virus down in big locales. A virus can, you'll hear a lot of noise out there. A virus is a very weak creature with one very weak piece of protein, with one exception. If it gets inside the human body, it will replicate by the billions. But literally sitting on a countertop, despite what you read in magazines and stuff like that, that thing is going to die very soon. So if you lock down, you have to lock down seriously. Other countries did that, and that's why their curves have just dramatically fallen down. If, on the other hand, you're not going to, then you can take more of a horizontal approach, which is to really look at what we would call in the healthcare industry risk stratification. So you understand, okay, based on Pat's age, based on Pat's other illnesses, based on even Pat's location, we need to have a certain set of policies and procedures for Pat versus somebody else that's different. And that might change over time, but what might those policies and procedures be? If Pat is elderly, has some diseases, asthma, COPD, other conditions, and he's been exposed, well, we should have a doctor or a nurse calling on him. We should have rapid testing of him. At the first signs of symptoms, we should make sure that there is an ICU bed allocated to him, et cetera, right? The bottom line, Mark, is we didn't really do either of those. So what I would advocate, just to be honest with you, is probably in the initial throes of this discussion, it's unfair for me to criticize anything about it because the data wasn't out there. There was a lot of uncertainty. So I think an initial, sort of social distancing shutdown for a period of time, done appropriately and done truly, followed by what you're describing, is probably the correct path. But we unfortunately kind of didn't really do either of those. And sadly, we're paying a dear price for it now. So in the interest of time, I'll stop there. But Michael, I'll turn it back to you.
Thank you very much. And I want to, again, thank you for all of your responses today. And just make sure that I'd like to open it up for other questions. I know some people have submitted questions. I know I have one more that I've been kind of sitting on, but I don't want to. I don't see any.
Ask away. I will just tell everyone that I'm as open a book, believer in transparency as possible. So no silly questions, no off the record questions.
I had the opportunity to get a tour of Optum downtown, and they were talking about and showing us ways in which they could manage care, because they could start understanding the activities of someone while they're at home, such as, are they taking all their medications? Are they taking them timely? And getting feedback and data due to artificial intelligence that was really not available before. And this is it was starting to become available, and I don't know where it's at in the implementation phase. But I guess my question to you, and this is more of a broader healthcare question, is how do you see artificial intelligence playing a part in being able to treat and I use the term population, an entire population being our country, not just a large employer. How do you see artificial intelligence being able to impact that and change your role as a physician, as part of the healthcare community?
Sure. Yeah, happy to. And just full disclosure, as I mentioned before, I used to be a senior executive at Optum. So what I'm about to say does not represent the views of, no, I'm just kidding. That disclaimer. But a couple of comments. Technology in healthcare is ahead of other aspects that slow that technology down. So let me give you an example, non-healthcare. If most people knew, I have a friend who's a pilot, if most people knew that on a 747 or a 777, that an autopilot is flying that plane for 99% of the time, a lot of people would be a little freaked out. But the technology is really good, and it's got a human being there. Doctors right now are extremely good, but technology can help us. But a few things prevent the adoption of technology. One are just behaviors. Up until COVID, people used to be suspicious about telehealth. Now people are like, oh my God, I get it now, right? Another example would, so behaviors, regulation. Do you need Dr. Basu to let you know that test is positive? For certain things, maybe yes. For certain things, no. A pregnancy test with a positive or a negative probably doesn't need a Dr. Basu to tell you whether it was positive or negative, but certainly a cancer, genomic profile might, right? So there's those elements. And then there's the status quo. Who's going to sort of rebel against whatever technology is coming? All of those caveats notwithstanding, a huge role for artificial intelligence. In your specific example, this is not even artificial intelligence. Right now with remote monitoring, you should be able to tell whether Pat is taking his medications. I should get a reminder. If I didn't take it, the doctor should get a reminder, because if I don't take those medications, or I miss or I'm not eating, or I'm not doing certain things, that could be really harmful to my health. And so that's not even artificial intelligence. That's just using 2010 technology to do good things. And we need to catch healthcare up to the year 2000, I often say. As far as AI goes, absolutely. There's been at Optum, we were in a project with Aetna to basically say, with CVS, can you determine, whether somebody's purchasing, not Big Brother like, but if somebody's purchasing cigarettes instead of mouthwash or toothpaste, should that person get like a digital reminder that tells them that their health could be at risk, or certain things like that. Obviously, lots of society level things to consider there, but definitely if I look at the habits in a day between what I eat, the medications I may or may not have to take, or other things like that, AI can really help you. And as you mentioned, at a population level, it should really help with COVID, right? If it can tell that somebody's getting symptoms, or somebody's acting in a certain way, then that might catch the issue before it becomes an even bigger problem. So I think there's a huge potential for AI, Michael, going forward. But it won't be the AI that limits us. It will be our policies, our kind of behavior change, and somebody on the status quo, some special interest that says, boy, if that technology comes to bear, it can harm me. I need to stop that technology from happening.
Awesome. Thank you, Pat. And I want to thank you for joining us today. We have recorded this, and I just want you to know that we're going to be forwarding this out, and we're going to be sending out several newsletters, and it'll go on our social outlets and things like that. So while we had a good group today, we're going to have several hundred more people get a chance to hear from you. So I really appreciate your generosity with spending your morning with us.
My pleasure. Anything Illini related always comes to the top of my list. So go Illini, and happy to do so.
All right. Thanks a lot, Pat. We'll talk to you soon.
Thank you. Thank you very much. Thanks all. Take care.